My name is Allie,
I'm Jake.
and our study is the effects of body weight supported treadmill training and balance training on functional walking mobility in persons with chronic TBI, a case study. A traumatic brain injury is trauma to brain tissue caused by an external force, which results in a cascade of cellular changes which further spreads the damage to other parts of brain tissue. Some statistics are that 1.1 million Americans will encounter TBI each year, and from those 1.1 million Americans, about 50,000 of those will die. To date, 3.2 million Americans are living with TBI-related disabilities, and the most common cause of a TBI is a fall. So this affects our central nervous system, which governs everything we do within our body. So common impairments are deficits in strength, tone, coordination, synergy, posture, and balance. And you can also see changes in cognition, behavior, and emotion. And from those impairments, we can conclude that possible activity limitations could be in ambulation, transfers, communication, activities of daily living, and our overall functional mobility. So the purpose of the study was to examine the effects of a body weight supported treadmill training module combined with a balance training module on the effects of overall walking mobility in a person with a chronic TBI. And balance is important because it governs all of our activities that we do every day. So it's a prerequisite of our functional mobility. So it governs our postural control because that helps us navigate our environment. So when we do encounter an obstacle, it has a huge role in correcting improper movement, so then it can just change whatever faulty behavior we're doing to allow us to be successful in completing that task, which overall affects our safety.
Going into the benefits of body weight supported treadmill training, a study by Bowden showed that there are 4 neurological impairments that lead to difficulties with gait training in patients. They include decreased strength, cardiovascular demand, decreased dynamic balance, and decreased motor control. Body weight supported treadmill training allows you to work on all 4 of these neurological impairments while decreasing the physical demand on the physical therapist. This decreased demand allows the therapist to give the patient more verbal and physical cues, which help to decrease gait deviations while also facilitating a more normalized gait. This is also a task-specific activity, which is integral in motor relearning for patients with neurological deficits. Going into the subject for this study. This subject is a 19-year-old male who suffered a TBI in December of 2011 after a snowboarding accident. And this was not a normal snowboarding accident that you guys might be thinking of, where he's coming down the mountain and collides with somebody or something. He was at the base of the mountain wearing a helmet, and he just fell over. And when he tried to get back up, he collapsed, where he was then taken to the emergency department. And he had a Glasgow Coma Scale score of 3, which is the lowest possible score on the scale. It basically means he was unresponsive. From there, they discovered he had a subdermal hematoma, which was then treated by a craniectomy, which is where you remove a portion of the skull to decrease pressure in the brain, in the head. He later had a cranioplasty to put that portion of the skull back on. His current presentation. So first and foremost, he had synergistic movements, which basically means he couldn't isolate muscle movements all throughout his body, which was most present in his left upper extremity, although he did present with some synergistic patterns in his bilateral lower extremities. Going off this, he also had tone, again, most evident in his left upper extremity. However, he did present with tone in his bilateral lower extremities too. He had decreased tone in his trunk, which led to decreased strength of his trunk muscles. And all of this together led to decreased balance. And then his most limiting factor was his ataxia, which was secondary to poor coordination. During his gait, we noticed multiple gait deviations, including decreased heel strike, decreased toe clearance, increased posterior trunk lean, increased scissoring, and occasional hip circumduction. Going to the methods, we chose 4 outcome measures to measure the patient's progress. We chose the 6-minute walk test to measure his endurance, the tug, or timed up and go, to measure his transfers, ambulation, and gait speed. We chose the Berg to assess multiple facets of his balance, and then finally the modified functional reach test to measure his dynamic balance.
So we developed 2 8-week modules to address his deficits. So we met once a week for 45 or 90-minute sessions. The first module consisted of balance retraining for about 90 minutes per week, and then the second module was based on the body weight support and treadmill training, which we met for about 45 minutes each week. Both these modules were progressed in difficulty when the patient reported a 4 out of 10 RPE or less, or when we noticed less and less compensations. So first was the balance module, and the purpose of this was to build the balance and the muscle coordination to be successful in the distracted stepping exercise, which I'll explain in a minute. So to get to that point, we developed a module that progressed his balance from seated into standing. Then we looked at within his base of support, and then progressed him with activities outside of his base of support. Then we did a progression from static balance into dynamic balance. And once we were comfortable with him standing, we progressed into weight shifting activities, which led into our distracted stepping exercise. So this was adapted from a study done by Leach, and this was done within the parallel bars. So the idea behind this was to focus the attention of the subject away from the actual task of weight shifting into an external target. So then the idea would be that the actual task of weight shifting would become subconscious, and that would result in that activity being a lot more smooth and coordinated, which was definitely seen in our subject. So we started this by asking him to move a leg that we picked towards a target that we picked. So then that was progressed further into moving across midline, moving further out to reach further targets. We could also reach backwards towards a target, which was also great in facilitating truck rotation to turn around and find that target. And then we would increase this difficulty further by increasing the cognitive demand by giving him a sequence of targets to reach. And that also showed a great improvement in his weight shifting, and it was almost effortless and it was smooth. And this was a great pre-gait activity that transitioned well into the body weight support and treadmill training module.
So this is the body weight support and treadmill module. First, this is the apparatus we used. It used air pressure to lift the patient up through this harness to partially unweight him. We started unweighting him at 38%, and we went through this progression to make the activity more difficult. We started by trying to get him to fulfill 45 minutes of gait training per session through 3 intervals. So every interval would end if he either completed 15 minutes of gait training for that interval, or he reported an RPE of 7 out of 10. At the end of each interval, he took a break for 3 minutes where we stretched out his gastroc. So first, the progression was obviously to increase that time to the total 45 minutes. And then we increased the preferred walking speed. So it started at 0.6 miles per hour and moved to 0.7 miles per hour. And then we tried to get it to go to 0.8 miles per hour, but the patient presented with a lot more gait deviation. So we went back down to 0.7 miles per hour for the duration of the study. Then we looked at his upper extremity support. He started at the beginning of the module with 2 hands on the treadmill for support. And then on week 5, we took off his hands from the treadmill, trying to normalize his gait further with increased arm swing and trunk rotation. However, the patient still liked to hold his hands into midline, so we focused more onto the trunk rotation for the duration of the study. And then finally, we tried to unweight him further, getting down to 31% body weight supported by week 8. Going into the results of the study, first the 6-minute walk test. From baseline to post-intervention 1, he did meet the MDC of 36.6 meters. However, in module 2, he did not meet that MDC. Overall, however, he did, from baseline to post-intervention 2, he did meet the MDC of 36.6 meters. Going into the tug, he, from baseline to post-intervention 1, he met the MDC of 2.7 seconds for Module 1, and then in Module 2, he did not meet the MDC again. However, overall, from baseline to post-intervention, he met the MDC of 2.7 seconds.
In the modified functional reach test, from baseline to the end of Module 1, he did surpass the MDC of 3.7 centimeters. Then in Module 2, pre to post intervention, he was just short of the MDC. However, from baseline to the end of Module 2, those improvements were overall greater than the MDC. And then in the Berg balance scale, from baseline into the post-intervention test of Module 1, he improved on 1 point in the Berg balance scale, and then that improvement was the same throughout the rest of the intervention, not meeting the MDC of 4.4. So this is the first study to date that compared and combined the body weight supported treadmill training with a balance training on a subject with a chronic TBI this far past injury. So we did see improvements in outcome measures, quality of gait, and motor control. And although in Module 2, it does not appear that those outcome measured numbers are better than how they were pre-intervention, they do show, we were able to observe an overall improvement in the quality of gait and the motor control. However, the scales that we chose were not sensitive to detect just improvements overall in the quality of his movement. So this was awesome to see that he was able to make these improvements 6 years post-injury, which is far outside of the typical optimal window of return, which is about 6 months to about a year initially past the injury. So this shows that improvements are possible to achieve way far past that initial injury, and PT intervention is beneficial to continue past that optimal window because return can be seen further out.
Going into the limitations of the study, first of all, it is a case study, so it cannot be generalized to the population of TBI. And going off that, we did provide manual assistance during 2 of the outcome measures, the 6-minute walk test and the tug. We provided manual assistance because the subject could not safely perform these measurements without the manual assistance. This does destandardize these measures. However, he did show improvement from baseline to post-intervention. Then going into the most difficult part of the study was the harness. It showed us a lot of challenges. Multiple times in multiple sessions we had to readjust the harness, and then in some sessions it worked perfectly, adding more variability to each session. Finally, the last limitation was the frequency. We planned this out for 1 session per week for 8 weeks in each module. And if you're learning or relearning anything, this is not the optimal frequency to be practicing such tasks. Finally, going into the conclusion. Although this is a case study and these results cannot be generalized, the results show a potential benefit for others with this diagnosis, as well as potential functional return well past the optimal window of recovery. Any questions?